All right. This is pretty dry, but I'll hopefully won't make it too dry. And if you have any questions as we go through this, just ask. So we're going to talk about cholesterol management today, and I thought I'd start with talk a little bit about coronary disease. And since we all work with coronary disease, clearly it's a major cause of death and disability in developing countries. What's interesting is because of everything that we've learned and everything that we do, mortality rates have actually declined over the past 4 decades, but still it's responsible for a third of all deaths in an individual over the age of 35. And in the United States, half of all middle-aged men and a third of all middle-aged women will develop coronary heart disease. So our jobs are secure. In 2018, the American Heart Association reported that 16.5 million persons greater than the age of 20 have coronary disease. In that 16.5 million, there's a slight male predominance of only 55%. The age standard death rate has decreased 22% since 1990, but the absolute number of deaths have actually increased due to shifting age and demographics. And there's also disturbing new data that the death rate is actually starting to rise from heart disease instead of continuing to drop. All of our data initially came from the Framingham Heart Study, and people that have not been involved with heart disease for a long time may not know that this actually comes from a town in Massachusetts. And Framingham was chosen because it's 20 to 30 miles away from Boston, so it was within driving distance of the large medical centers. And also Framingham, the town, had been used for TB studies prior to the initiation of this study. The Framingham study was actually started in 1948, and it was started by what was then the National Institute of Health, but is now the National Heart, Lung, and Blood Institute. And initially it enrolled 5,209 men and women between the ages of 30 and 60. And it was to study the evolution of heart disease and identify risks of heart disease. And when you think back to the 1940s and 1950s, everything that we do now in terms of treating blood pressure and cholesterol, we didn't even know that those were risk factors prior to that. The Framingham study is a long-term, multi-generational study. It's actually still in progress. They're now in the 3rd generation. And it's designed to identify the genetic and environmental factors influencing the development of cardiovascular disease. There's well over 1,000 scientific patients. And it's really made a major impact on our understanding of cardiovascular disease, prevention and treatment of MI and stroke. Since the 1960s, after they had been doing this epidemiological study for about 12 to 13 years, it was identified that cigarette smoking was a risk for heart disease, increased cholesterol, hypertension, obesity, lack of exercise. And prior to this, these were not identified as risk factors for heart disease. So really, a lot of what we understand about heart disease comes from this Framingham study. Because they were looking at a whole town, we also got information regarding triglycerides, the role of LDL cholesterol, a lot of information regarding mitral valve prolapse, heart failure, atrial fibrillation, stroke, diabetes, risk in ethnic minorities, and this was the first time they were also looking at the role of estrogen in postmenopausal women. So this has been a very comprehensive study. It is still ongoing. The current emphasis is identifying genetic and molecular risk factors for heart disease and other cardiovascular disorders. As I said, they're now on the 3rd generation of the original cohort, and they're also attempting to further understand genetic factors. From the Framingham Heart Study, we know that at the age of 40, the lifetime risk of developing heart disease is 49% for men and 32% for women. And this is kind of a recurring theme that in Americans, there's a very high incidence of heart disease. By the time you get to 60, the lifetime risk has decreased because all of those men have died that had heart disease, basically. So those that are left are healthy. So their lifetime risk is 35%, and for women, 24%. Coronary events, the incidence steeply raises with age. When you're looking at the coronary events between men and women do lag about 10 years behind men in terms of developing coronary disease. For MI and sudden death, women lag about 20 years behind men, but as we age, that sex ratio actually narrows. So when you look at young people from 35 to 64, and you compare them to their older cohort of 65 to 94, the risk of heart disease doubles in men and triples in women when you're looking at those two different age groups. So as we get older, more things develop and we have more heart problems. Framingham was one of the major studies that looked at the difference between men and women. In premenopausal women, coronary disease is rare. The caveat to that is clearly people who are diabetic and smokers. Beyond menopause, the incidence and severity of coronary disease increases abruptly, and the rate is 3 times higher for women who are postmenopausal as compared to women who are premenopausal. So if you're looking at a 48-year-old woman who's had an early menopause and a 48-year-old woman who's still menstruating, there's a tremendous difference in their risk of heart disease. Below the age of 65, the annual incidence of heart disease in men is 12 per 1,000. This more than equals the rate of all atherosclerotic cardiovascular events in women combined, which is 7 per 1,000. When you look at the incidence of heart disease between men and women, the incidence is less, and yet still heart disease is the #1 killer of women, and that's one thing that we always have to remember, that even though the incidence is less in women, it is still the #1 killer. And over the age of 65, coronary disease still predominates as a major cause of death. There are some differences between the presentation of heart disease. The male predominance in heart disease, they have less angina. They tend to present more with myocardial infarctions and sudden death. Under 75, women present with angina, which is likely to be uncomplicated, less heart disease and sudden death in that group. In men, angina occurs after the MI and not so much before the MI. And infarction predominates at virtually all ages in men. Only 20% of infarctions are preceded by long-standing angina in men. So chest pain is actually a little less common in men prior to their MI. Now we know until just very recently there's a declining incidence of coronary disease, but there's been no decline in the incidence of MI. And one of the reasons for that is because we're getting better and better at diagnosing MIs, and because the troponin assays are so sensitive in terms of diagnosing MI, even when just a very small amount of the myocardium has been damaged. There's also been an increase in the non-STEMI MIs from 19% in 1994 to 59% in 2006. And a part of this is mostly the diagnosis and increasing the diagnosis. In 2015, the death rate was 223 per 100,000. That had been a significant decline. The death rate is higher than men than women. The death rate's higher than blacks compared to whites. Mortality had dropped almost 50% since 1975. The decline in mortality has actually slowed, and from 2005 to 2015 there was a 22% decline in the death rate. In the declining death rate, half of it is due to improvements of everything you do in the ER, how you treat MIs, how you treat heart failure. But half of it is also due to lifestyle changes and risk factor management, particularly cholesterol management, blood pressure, decreasing smoking prevalence. In the United States, I think about 22% of the population still smokes, and it's actually more towards the younger population, the teenagers, the 20-year-olds that are still smoking. Unfortunately, the decline is being offset by increases in BMI and the prevalence of diabetes, which is accounting for an 80% increase in the number of deaths. So, you know, we are seeing disturbing increasing death rates just in the recent few years. Non-obstructive coronary disease is kind of near and dear to my heart. When somebody from chest pain goes into the cath lab and the guys can't put a stent in, they think the disease is not obstructive and minimal. These are the patients that we have to worry about. And heart disease takes years to develop, and generally people are asymptomatic for years. And the presence of any heart disease is associated with a worse prognosis compared to no heart disease identified. So that these people, now that we're getting the CTAs on and their calcium score is negative and their FFR is completely clean, those people really have a very, very good prognosis, where the 20, 30, 40% people are the ones that we have to worry about. And the VA looked at all of the people that they were capping between 2007 and 2012, and again, these were people that did not get stented, did not have critical coronary disease. And the risk of MI is higher if you have one vessel with non-obstructive disease, and that risk progressively increased with the number of vessels that have non-obstructive coronary disease. Unfortunately, we have no prospective research at this time on non-obstructive disease, but because of the incidence of heart disease is so high in these people, these should be considered for very aggressive secondary prevention. Just because you can't put a stent in them doesn't mean they don't have heart problems. This is one of my favorite proverbs. Inferior doctors treat full-blown disease. Good doctors treat the disease before it's evident. Superior doctors prevent disease. And that's what we're all about, preventing disease. Okay, let's talk a little bit about cholesterol. Cholesterol was actually first identified in 1784. They found it in gallstones. This has been an incredibly active area of research, and there have been 13 Nobel Prizes awarded to the cholesterol story, to identifying cholesterol, to identifying the mechanism of the manufacture of cholesterol, and also identifying ways to treat cholesterol. So this has been 13 Nobel Prizes. Statins were first approved in 1987, so we've now had statins for a little over 40 years. We have had guidelines for how to treat cholesterol. We've been through many guidelines, and they were first established in 1985, and then there were the National Cholesterol Education, NCE, I think it was panel, NCEP put out the initial guidelines, and then ACC and AHA started putting out the guidelines in coordination with a lot of other organizations. The guidelines that came out in 2013 were probably the most confusing because they did not give specific set goals. What they were talking about is percentage of drop and how important that was, and I think that was very confusing to a lot of people. But what they were trying to say is, when you have somebody with an LDL cholesterol of 300, with the medications they had available at that time, if you drop it 50%, you're providing tremendous benefit for that patient, even if you're not getting them to 70. But that was a difficult concept for a lot of people to understand. And our most recent guidelines were in 2018. These guidelines sponsor development of clinical practice guidelines without commercial support. So these are very clean guidelines. There's no industry input into these guidelines. And the people that write them and review them volunteer their time. And the important thing about guidelines is the practitioner has to follow them and the patient has to follow them to be effective. And sometimes it's been very difficult to get practitioners to understand the guidelines and to embrace the guidelines in their own practice. And we know how effective the guidelines are, so it really helps if everybody's on board with them and following them. And the people that write these guidelines, they keep working on making them shorter and more user-friendly. Still probably some room for improvement in that area. In terms of cholesterol, the LDL is still the dominant form of atherogenic cholesterol, and pretty much all of the research is geared to LDL cholesterol. There are a lot of other components to the cholesterol particle. VLDL is very low density, and that's a chief carrier of the triglycerides. This is a very atherogenic particle. HDL is the one part of the particle that seems not to be atherogenic. Efforts to increase it have been fraught with difficulty. The whole classes that have been trying to increase the HDL have never made it to market. Chylomicrons transport dietary fat. Their atherogenic Atherogenicity is uncertain. when people have very high triglycerides and if they have very high chylomicrons, when you draw their blood and if you set it on the counter, the cream will actually rise to the top, and that's the chylomicrons. And that's not a good thing. You don't want cream rising to the top in your blood. LDL and VLDL equal the non-HDL, and when you look at our lipid panel, there's a component there that's a non-HDL. And this combination is more atherogenic than just the LDL together. The proteins of the LDL and VLDL are embedded on the ApoB. That's not something they routinely check, but that can be checked. And the stronger indicator for atherogenicity than LDL. So the ApoB, if you have a very high ApoB, is a much stronger for atherogenicity than even the LDL. Risk factors for heart disease, we pretty much understand them. There are some genetic variations and some family problems that still trip us up, but clearly we know that LDL is the primary cause of atherosclerosis. Cigarette smoking, hypertension, blood sugar problems, other lipid abnormalities. We know that atherosclerosis progresses with advancing age. And the Framingham Heart Study took a look at creating what are called risk prediction equations, where you can actually put these numbers in and come up with a percentage of how high a risk somebody is, and usually that's less than 5%, 5 to 7.5%, 10%, or 20%. So it's from these risk factors that we have our equations trying to identify people's risk of heart disease. Talking about ApoB and Lp(a), if a patient's very hypertriglyceridemic, and those are all the patients I get because nobody knows what to do with them, so triglycerides of 1,000, 2,000, 3,000, that's what we see in our clinic. Measuring ApoB has advantages because you don't see an LDL in those patients, because with the triglycerides you can't get an LDL. However, the measurement of this does carry extra expense and it's not always reliable. Lp(a) is another form of LDL. It's a very small, dense LDL. Indications for measurement are when there's family history, but the cholesterol actually doesn't look that bad, or personal history of heart disease with no other explanation in terms of the risk factors. So these are things that we do not routinely test, but there are indications for testing them. When the Lp(a) is high, there's an increased risk of heart disease, and generally that's greater than a number of 50. This is called a risk-enhancing factor. I actually get a fair number of people that come in just with an Lp(a), and sometimes you see young, healthy women that genetically have this high Lp(a), and it's really hard to figure out what to do with them if they don't have an elevated cholesterol. And really, there's nothing that treats this, unfortunately. So the recommendation is there's no indication to treat this unless their cholesterol is also elevated. In randomized clinical trials, we know that lowering the LDL has been consistently shown to reduce the risk of heart disease, despite what patients read on the internet. LDL is very important for decreasing the risk. In clinical practice, the absolute response in LDL to statin therapy really depends upon the baseline of LDL concentrations. Generally, given doses produce a similar percentage reduction, and across a broad range of baseline LDLs, the more reliable indicator of efficacy is, again, the percentage of reduction. But people actually feel more comfortable with a number where the efficacy really is in the percentage of dropping the LDL. The percentage reduction is used to monitor patients and estimate the efficacy of statin therapy, and generally a 1% lipid lowering decreases your risk of heart disease by 1%. So when you have somebody that has difficulty taking medication, whatever you can give them, whatever amount of LDL you drop, you are dropping their risk of heart disease on a 1-to-1 ratio. We talk about high-intensity statin, moderate-intensity statins, and with high-intensity statins, you're expecting a greater than 50% risk of LDL lowering. This would be atorvastatin 40 or 80 or rosuvastatin. I think I maybe only have 1 or 2 patients on rosuvastatin 40 because rosuvastatin has turned out to be very powerful. Moderate lowering is in the 30 to 49%, and that's most of your other medications in moderate doses. There are people that don't need a great deal of lipid lowering, and simvastatin, and again, the very lower doses of medication achieve that number. Now, I see mostly patients who are statin intolerant, and the one caveat I would say to this is that when people are very, very sensitive to medication, sometimes even a very low dose drops them 50% because of their sensitivity to medication. So when they're treating MIs, when people are in the hospital, they just routinely slap them on 40 of atorvastatin or a medication, and then they come into me and they've stopped the medication because they feel bad. It is worth trying a very small dose of these medications because there are some people that will get a 50% drop with just a very low dose of statin. And one of the reasons we spend so much time talking about statin therapy, and we'll get into cost analysis later, but I think there's only one statin that's now brand name, so these are all generic. They're all tier 1 on people's insurance, and some of them are even free. So when you start talking about, and we'll talk about PCSK9 inhibitors, but when you're talking about medications that are incredibly cost effective and incredibly inexpensive, it's hard to beat the statins if you can get people to take them. Okay, let's get into the guidelines. Everybody and their brother was part of these guidelines, as you can see. There's a lot of work that goes into these guidelines and a lot of people that spend a lot of time. And there are various places that you can find these guidelines. This is just the writing group that's listed on this, and these are all people that are very invested in cholesterol management and prevention. The takeaway from this slide is, in terms of the class of recommendations, green is clearly go, red is stop. So the strength of recommendations is color-coded, and the quality of evidence, the darker blue, the better the quality of evidence. So, I mean, it looks kind of overwhelming, but when you go through these guidelines, if you've got a green and a dark blue, you've got the best evidence, basically. And none of it is in red. There's nothing in these guidelines that is contraindicated. But when you're reading other pieces of evidence, that's what you're looking for, is what is really contraindicated or not beneficial. So the 2018 cholesterol guidelines. Recommendations are for adults 20 years or older, that basically to screen them. So these are people that you have no idea where their lipids are, not necessarily at risk of heart disease. But what happens is, because heart disease is so common in the United States, what we're trying to do is find out who is at risk. And you would not believe the number of 18 and 20-year-olds I have with cholesterols of 400 and 500 because they were just screened. And this is when you're trying to pick these people up, when they're young and trying to make changes as quickly, as soon as possible. So just a non-fasting lipid is appropriate as a screening tool. If their triglycerides are elevated, then a repeat fasting lipid profile is what would be recommended. And this is really recommended as a screening tool for all young adults. Recommendations for measurement of LDL. For patients with an LDL less than 70, measurement of a direct LDL or modified LDL. This has to do with some of the protocols that are used in the lab, and it just says if somebody has a really low LDL, you may want to look at it another way, but a really low LDL is really a good thing. When patients are 20 years or older without a personal history, but with a family history or genetic hyperlipidemia, recommend a fasting lipid profile. And you will see those people, and they do come in. And one of the reasons they come in is because of the family history. You'll see a lot of those patients. The easiest guidelines are the secondary prevention guidelines. So these are people that already have heart disease, and these are the clearest and easiest guidelines to understand. So for patients who are 70 years or younger who already have clinical heart disease, high-intensity statin therapy should be initiated with an aim of achieving 50% or greater in the reduction of LDL. In patients with clinical heart disease and whom high-intensity statin therapy is contraindicated or who experience statin-associated side effects, which in my practice is everybody, moderate intensity statin therapy should be initiated and continue to with the aim of dropping the LDL cholesterol at least 30 to 49%. So high intensity, if they can't take high intensity, go with the moderate intensity. Or basically, as I say in my clinic, find anything that they can take. In patients who are very high risk, consideration of PCSK9 inhibitor therapy for maximally tolerated LDL lowering therapy should be included, in addition to the maximally tolerated statin therapy and ezetimibe. Now, this is the first time the guidelines bring up PCSK9. And what I can tell you is these medicines have been a total game changer. They're phenomenal. They were approved 3 years ago, more than 3 years ago. They lowered the LDL for almost everybody to about 50. They're extremely well tolerated. Unfortunately, they're also obscenely expensive. But they do start adding these in here because these medications have turned out to be so good. In patients with heart disease who are judged to be very high risk and who are on maximally tolerated LDL lowering therapy with an LDL 70 or higher, it is reasonable to add PCSK9 inhibitors following a patient discussion with the net benefit, safety, and cost. And when we get into this discussion with patients, it's always that discussion. And the other thing, and I think everybody here probably is using these medications, the approval process is a lengthy and very time-consuming process. So as I explained to patients, this is the one class of medicines that you don't prescribe and you run down to your pharmacy to pick it up. It's always denied by their insurer, and it always initiates a denial process and approval process to get this medication for people that can take anywhere from three weeks to 6 weeks or even longer. I think that the approval process has gotten a little bit better, but it's still very onerous and very time-consuming. Getting into a little further down in the recommendations, in patients with clinical heart disease who are on maximally tolerated statins and still judged to be very high risk, go ahead and add ezetimibe therapy. And ezetimibe has been generic now for a couple of years. It has always been a very effective means of therapy. All the years that it was brand name, it was very difficult to use because it was very difficult to get approval for it. But now it's something that you should routinely think of adding to people because it is also generic and very well tolerated. It generally does not have the muscle-associated side effects except for your people that are incredibly sensitive to everything. The problem with ezetimibe is the way it works in the body. You have to have a protein for the ezetimibe to bind to in the GI tract to work. Some people have that protein and have a very excellent effect. There are other people that will not respond to ezetimibe, and it's because they don't have that specific protein. So if you get ezetimibe started and you see nothing, there's no point in continuing it. They're not going to respond. By the mid-2018 list price, PCSK9 inhibitors have a low cost value that's greater than $150,000 per quality average life year compared to a good cost value. And again, all of the statins are generic and tier 1 and incredibly inexpensive. Okay, still on the secondary prevention, in patients older than 75, which we see a ton of. So we see, clearly we see a lot of those patients that have clinical heart disease. It's reasonable to initiate moderate or high intensity statin when they develop heart disease, for heart disease reduction. They're at increased risk of adverse effects and drug-to-drug interactions, as well as you have to consider patient frailty and patient preference. But it's not, particularly, I laugh, our Jacksonville clinic, we have people in their 80s and 90s that are still working. When you have those patients that are still vital and still very active, treating them is very appropriate and is indicated by the guidelines. In these patients who are older than 75 years of age who are tolerating high-intensity statin therapy, it's reasonable to continue after evaluation of their potential risk reduction, adverse effects, drug-to-drug interactions, as well as patient frailty. And one thing you have to look at in these very elderly patients is as they age, how they metabolize medicines change, and frequently you need to keep monitoring their levels and make adjustments because how they metabolize medicines and their other medications, and as their number of medications start increasing, you really have to look for drug-to-drug interactions. And again, looking at these older patients, in patients who have heart disease who are receiving maximally tolerated statins, and the LDL remains above 70, ezetimibe, don't forget ezetimibe, add the ezetimibe. In patients who have heart failure, which is a different class of patient now, but again a very common class of patient with a reduced ejection fraction attributable to ischemic heart disease, who have a reasonable life expectancy of 3 to 5 years, and most of our heart failure patients now do have that. If they're not already on a statin, people should consider adding at least moderate intensity statin to reduce the occurrence of heart events. So we see a lot of heart failure patients, and with all the medications that we have for them now, most of them do have an increased life expectancy and do deserve to be treated. Secondary prevention. At the top, one thing that should be part of all of these guidelines is a healthy lifestyle, talking to people about a healthy eating pattern and good exercise pattern, and so that's part of all of the guidelines and should be discussed with everybody. If you go off to the left and you're looking at your very high risk patients, all of these patients, that's right, I'm a little, let's see, is that right? Yeah, that's right. A little dyslexic. Off to the right, you're very high risk, all deserve aggressive treatment. They all should be on high-dose statins or whatever statins they can tolerate to get their LDL less than 70. Add ezetimibe for these patients, and also on these patients, these are patients which you would consider adding PCSK9 if you cannot get them to goal or if they cannot take medications. When you're off to the left, to the far left, your patients are less than age 75, have heart disease, again, very aggressive treatment. And these, as the dose of statin that they're able to tolerate, add Zetia if you can't get them there. That middle one is the patients that are over the age of 75, and this is more moderate intensity statin, and basically find medications that they can tolerate and consider ezetimibe for these patients. So when you break it down, it's really not that difficult of a slide, because off to the right are your very high risk, off to your left are not quite as high a risk. And when you think about it, this just all makes sense, right? The younger you are, the more aggressive you want to be. The highest risk for heart disease, the more aggressive you want to be. Okay?
I have a question, Dr. Novak. How do you deem somebody high risk versus like
That's where you do the risk calculator.
Okay. Got it.
Yeah. If they have heart disease, they're very high risk.
Okay. It just says ASCVD not at very high risk and then very high risk ASCVD. So is it based on the calculator that you determined? Okay.
Yeah. Patients who are very high risk of future events are anybody who's had an acute coronary symptom within 12, and so this is the very highest risk here.
Got it.
Your acute coronary syndrome within 12 months, a history of MI or other recent acute coronary syndrome, a history of ischemic stroke, or the ABI secondary claudication, previous revascularization or amputation. So again, vascular disease is a diffuse process. even if patients haven't seemed to have an acute coronary event, if they've got peripheral vascular disease, you need to treat them very aggressively as well. Other high risk, very high risk, age of 65 or greater, because again, the incidence starts increasing the older you get. When you have that family history of severe hyperlipidemia, and again, we see those patients that have the cholesterols of 3 and 4 and 500, that's a familial problem. A history of previous bypass surgery or PTCA or major cardiovascular event. Our diabetic patients, our patients with hypertension, chronic kidney disease, don't forget that patient population, and that's with a GFR less than 59. Current smoker. And you know what's interesting is most people who work now don't smoke because you can't smoke at work, you can't smoke when you go out to eat. But you'll find that those patients that are disabled or are retired who were smokers, they're sitting at home smoking. Mm-hmm. Because they're not in that situation where they have that control and absolutely cannot smoke. So you always have to ask our patients whether they're a smoker, and I find very often on our notes that isn't even addressed, and that really should be addressed on every patient and every time they come in. And persistently elevated LDL is also puts them at risk in a history of congestive heart failure. I mean, all the things that we already know. Okay, these are what put people at very high risk of heart disease. So let's look at the patients that have the very severe hyperlipidemic, and these are the LDLs greater than 190. When you have the familial hyperlipidemics, their LDLs maybe 200 to 300. And the recommendation is to start treating these patients even as young as 20. They need maximally treated with statin therapy is recommended. If their LDL remains greater than 90 and you achieve less than a 50% reduction in LDL, then the addition of ezetimibe is reasonable.
So you don't run a test to check the ezetimibe, it's just clinical history in diagnostic. I mean, there's not a test to check the
Whether
protein
there's not.
deficiency in that.
Yeah. We don't have the long-term data on PCSK9s. You know, I have a couple of 18 and 20-year-old people that have cholesterols of 500, LDLs of 300. I have been able to get them on PCSK9. You know, when you're looking at these really severe hyperlipidemics, you know what their history is, you know what their risk is. And so it's not in the guidelines, and I just hope there's long-term safety with these medications. And again, continue with the recommendations for these severe hyperlipidemics in patients 20 to 75 with their baseline very high levels. If you achieve less than a 50% reduction in LDL and the fasting triglycerides are less than 300 while taking maximally tolerated statins and Zetia, then consider the addition of bile acid sequestrants. Now, we've had bile acid sequestrants forever. That's the colesevelam, Welchol. Welchol has been around forever and a day, and it is still not generic, and it is still one of our most expensive medicines. The benefit, if you're adding a bile acid sequestrant to people with Welchol, is that you don't have to worry about interaction with their other medications. If you have to go back to the generic Clestabid, then their medication has to be taken an hour before or 4 hours after you take the bile acid sequestrant. So it's a very effective class of medicines. It's a difficult class of medicines to take. This is the bile acid sequestrants. If people aren't familiar with it, it's the powder that you mix up, the Clestabid, or the packets that you take. One of the indications for this is people that have chronic diarrhea from gallbladder problems, because it can be very constipating, and it's a very difficult medicine to take. And more patients that I've had on Welchol are being switched off their insurance to go to the generics, which then brings in all those timing with their medication and eating. So an effective class of medications, but a problematic one. And the other thing is that they will increase triglycerides, so they can only be used in patients that have low triglycerides. In patients with a heterozygous familial hyperlipidemia that are still not at goal, then they're recommending PCSK9 inhibitors. Okay, when you're looking at a little bit older patient here, 40 to 75, with severe hyperlipidemia, the baseline LDL greater than 220 or higher. With treatment, the LDL level is still 130 or greater. Then you're looking at maximally tolerated statins, Azedia, and again, PCSK9 may be indicated. In patients with familial hyperlipidemia without evidence of clinical vascular disease, taking maximally tolerated statins and Azedia therapy is appropriate. PCSK9 inhibitors provide uncertain value because of the cost. Okay, but your familial hyperlipidemics, I do think it's worth getting this for them. They're going to get into heart disease. You know they're going to get into heart disease. And actually, insurances have been better with these patients that have these incredibly high cholesterols, even at a young age, approving PCSK9. Our diabetic patients, basically anybody who's diabetic, you should think to have heart disease. In patients 40 to 75 with diabetes, regardless of what you would think of their 10-year risk factors, moderate statin therapy is indicated because the diabetics have such a very high incidence of heart disease. In the patient 40 to 70 years of age with diabetes and an LDL of 70, basically over 70, it's reasonable to assess their 10-year risk of the first event by using race-specific guidelines and to help stratify their risk. So diabetics are very high risk and need very aggressive treatment. In adults with diabetes who have multiple risk factors, it's reasonable to prescribe high-intensity statins with an aim to reduce the LDL greater than 50% or more. In the older patient with diabetes who are already on a statin therapy, it's reasonable to continue the statin therapy. In adults with diabetes and a 10-year risk factor greater than 20% or more, which is the very highest risk for heart disease at 20% or more, then add ezetimibe for maximal total statin therapy, LDL reduction by 50% or more. So our diabetics treat aggressively, even if they're older, treat aggressively. In adults greater than 75 with diabetes, it may be reasonable to initiate statin therapy with clinical patient discussion of potential risks and benefits. In adults 20 to 39 years, so the younger adult, 20 to 39 with diabetes, that's long duration, so greater than 10 years with the type 2, greater than 20 years with the type 1. If they already have albuminuria, if they have a low glomerular filtration rate, less than 60, if they have the complications of diabetes with retinopathy, neuropathy, or any evidence of peripheral vascular disease, initiate statin therapy. Basically, your diabetic should just need to initiate statin therapy. So the diabetic-specific risk enhancers that are independent of the risk of diabetes is the duration of the diabetes and also the type of diabetic, type 1 or type 2, if they have albuminuria, if they have a low GFR, retinopathy, neuropathy, or peripheral vascular disease. Primary prevention is a much more difficult problem, and this is where you really get into trying to determine risk reduction. And you'll see we start, what they start with the primary prevention is even down to the infant when you have family history of familial hyperlipidemia, and then goes into very high risk. So we need to think of not only the risk factors, but there's something that the guidelines are coming up now which are calling risk enhancing factors. So these are in addition to what we think of as risk factors themselves. So a family history of premature heart disease, and of course that's in males the age of 55 or in females the age of 60, and that means cardiac event or a clear indication of heart disease. When the patient themselves have primary hyperlipidemia with a very high LDL greater than 160, metabolic syndrome, which we see very commonly in the metabolic syndrome, is an increased waist circumference, elevated triglycerides, elevated blood pressure, elevated glucose, and a low HDL, less than 40 in women, less than 40 in men, and less than 50 in women. And 3 of those make the diagnosis of a metabolic syndrome. That is probably one of the most common types of patients that we see that are coming in for evaluation prior to an MI. Chronic kidney disease, and we have to remember that our patients who have chronic kidney disease are very high risk of heart disease. Chronic inflammatory problems, rheumatoid arthritis, psoriasis, HIV, all of those inflammatory conditions, lupus, they all increase the risk of heart disease. For women, a history of premature menopause, or the other thing that is very important to talk about is a history of pregnancy-associated conditions, particularly preeclampsia, hypertension, or pregnancy-associated diabetes. This puts a woman at very high risk of heart disease as she progresses through life. There are also high-risk ethnicities, particularly South Asian ancestry and other ethnicities that put people at very high risk. So these are risk enhancing, which are additional to our risk factors that you need to think about. Let's look at biomarkers that are associated with increased risk, persistently elevated hypertriglyceridemia. In our clinic, we kind of laugh at triglycerides of 200 because we see such very high triglycerides, but even triglycerides greater than 175, and again, normal triglycerides are less than 150. An elevated high sensitivity C-reactive protein, elevated Lp(a). This is indicated for measurement in a family with a history of vascular disease without a lot of other risk factors. If the Lp(a) is greater than 50, contributes to a risk-enhancing factor. Elevated ApoB, remember back one of the first slides, ApoB is the carrier for LDL and VLDL. That's a relative indication of its measurement. That should be measured when the triglycerides are greater than 200, and if that level is greater than 130, that corresponds to an LDL greater than 160 and is a risk-enhancing factor. And of course, vascular disease, peripheral vascular disease. So primary prevention in adults 40 to 70 with LDL levels greater than 70. In adults at an intermediate risk, statin therapy reduces the risk of heart disease, and in the context of risk reduction, if a decision is made for statin therapy, a moderate intensity therapy should be recommended. In intermediate risk patients, the LDL level should be reduced by 30% or more, and for optimal risk reduction, and especially in the high risk patients, the level should be reduced by 50% or more. And again, this is primary prevention, so you're making that assessment of high risk or low risk depending upon risk equations, which you find they're not included in these guidelines, but you can find them in a lot of places, plus adding the risk enhancers. And again, in the patients 40 to 75 with LDLs greater than 70, in patients without diabetes, and a 10-year risk of heart disease should be estimated using the risk and sex-specific guidelines. Adults should be categorized as being low risk when that risk is less than 5%, borderline at 5 to 7%, and intermediate at 7 to 20, and very high risk at greater than 20%. And clinicians and patients should engage in risk reduction discussions that consider risk factor, lifestyle. Again, lifestyle is so important for these patients, talking about lifestyle, and the potential for risk reduction benefits and the potential for adverse reactions and drug-to-drug interactions, as well as patient preference and individual treatment decisions. So again, when you're looking at primary prevention, you need to decide what their risk is and then have a discussion with them. And again, always talk about healthy lifestyles. A really low risk patient, but if they're very concerned about heart disease, if they want to be very aggressive and if they want to take statins, it's reasonable to put them on a statin if they're very serious about protecting their heart. So it's all has to do with the discussion between your patient and defining what their risk is and also what their concerns are. In the intermediate risk patient, think about the risk enhancing factors, and these favor the initiation or intensification of statin. In the intermediate risk or selected borderline risk, if the decision about statin remains uncertain, then you can talk about using a calcium score to decide to withhold or postpone or initiate statin therapy. Clearly, if you're looking at risk factors and a patient doesn't want to take statins and you do a calcium score and it comes back 0, then you feel more comfortable not putting them on a statin therapy. Where again, if they've got evidence of early heart disease, you would be more aggressive about putting them on statins. So it's really nice when that definitive score of 0 comes back. That really helps. And again, you're looking at your patient 40 to 75. These patients at moderate risk or intermediate risk. If the coronary calcium score is 0, it's reasonable to withhold statins and reassess in 5 to 10 years. However, if they're diabetic or have a family history, if they're a cigarette smoker, you would be much more aggressive in testing them. If the calcium score is 1 to 99, it's reasonable to initiate statin therapy, particularly if you're over the age of 55. And if you have a high calcium score of 100 or higher, or if you're in the 75th percentile for age, then it's reasonable to initiate statin therapy. So again, everything that you're doing is trying to define what the risk is for these patients that are primary prevention. In the intermediate risk adult who would benefit from more aggressive LDL lowering and in whom high-intensity statins are advisable, but they are not tolerated, then it may be reasonable to add a non-statin drug such as the ezetimibe or bile acid sequestrant. Patients at borderline risk and a risk reduction, the presence of risk-enhancing factors may justify moderate intensity statin therapy. And in these patients, when they talk about patients having side effects, that's when you're looking at trying to find a dose that they're able to tolerate, or in a lot of these patients, I try a very tiny dose of a statin in addition to a medication such as Zetia to see if we can find a combination that they can tolerate. So a checklist in your risk assessment. You need to assign to a statin treatment group using their risk assessment, their risk estimator. In the lower risk primary prevention with LDL, the lower risk patients are patients that have LDL greater than 70, not needing a secondary prevention in those greater than 190 on their LDL. You need to assess other patient characteristics, such as the risk-enhancing ones, again, the chronic kidney disease, the inflammatory, all of those other things that we listed in the risk-enhancing. You can assess the coronary calcification if the risk decision is uncertain and additional information is needed. And there's ways to add the risk estimator tool. Review lifestyles with everybody. I try not to tell people about diet, but talk about more of a healthy eating plan. So healthy eating plan, physical activity, have a discussion about, if for people that are obese, start the discussion about weight loss. And, tobacco, cigarette smoking is the most addictive of human habits. And people who have been able to kick alcohol and even kick drug habits find that cigarette smoking is terribly addictive. It doesn't help to shame these patients. It doesn't help to be abusive to them. What you need to do is work with them to try and help them understand that you know how difficult it is and what can we do to work together to get you off the cigarettes. I have some patients that say I'll stop smoking when they put me in the grave. it's not worth wasting, it's, there's no sense wasting any more time on it. But other patients that want to stop, acknowledge how difficult it is and help them with, decide how to help. Unfortunately, again, for our poor patients or indigent patients, Medicaid is not very good about covering some of the medications that can help. But other patients, it is worth giving them the Chantix and nicotine patches. So this is something that we really need to work with our patients about. So endorse healthy lifestyle choices, provide relevant advice, materials, referrals. And there's lots of information out there for people. And lots of information in Epic to give them for dietary information, etc. In terms of the net benefit of pharmacotherapy, statin is first-line therapy. It's incredibly cost-effective and incredibly effective, and it's medication we've had for a very long time. Consider the combination of statin and non-statin therapy in selected patients. Discuss the potential of risk reduction from lipid-lowering therapy in terms of what you expect. It's really amazing when people start taking their medication how very effective it is. And discuss the potential for adverse effects or drug-to-drug interactions. Cost considerations are very important. I just had a patient in Jacksonville who has all sorts of complications and all sorts of problems. He's on, I think, Eliquis and Entresto. He's Medicare. He's paying $500 a piece for each drug per month. Yeah. So when we use these brand name new line therapies, you really should consider the burden to the patient and have that discussion with them. And if they come back in and they're not taking their medicine, have the discussion of what the cost is. Okay. Obviously, if patients have insurance coverage, it's a whole lot easier if you can get things covered and you can work with copay cards. Tier level is very important to the cost, and co-payments are very important. Patients will not take medication if they're having side effects, and there are patients that can't afford to take medication. This should be a shared decision-making. Encourage the patients to verbalize what they've heard, so patients understand what their personal risk is for heart disease, what the options are in terms of treatment, and what the risk benefits are. You should invite patients to ask questions and state their preference. People say, I don't want to take any medicine. Well, you're diabetic, you have heart disease, and you have cholesterol. Not taking medicine is really not an option. Encourage adherence to lifestyle changes and medications. Everybody goes online, everybody's looking at material. Encourage them to use trustworthy sites. I really encourage patients to go to the American Heart Association site. If they're diabetic, go to ADA. A lot of information there regarding medications, dietary choices, dietary plans. There's a lot of information out there, and you need to try and steer them toward what is reliable and trustworthy. And you really need to have a collaborative approach with your patient in terms of treatment. Yes?
What EPIC educational material are you using for your patients?
Dietary stuff?
Yeah.
Yeah.
Are you using the...
In your after visit, when you go to print up your after visit summary, up in the top where it says references, if you click on that, it'll click on stuff that's related to their diagnosis. But like for diet information, you can type in, just click additional and type in cholesterol diet, type in DASH diet, or like a keyword, and it will bring more information up. Just click on it, add it to the discharge summary, and print it up for them.
So are you using mostly the low cholesterol for these?
Well, with some that have like high triglycerides, you can type triglycerides, and it has a education for foods that have high triglycerides in them. It's got like portion sizes, amount of servings. It's really good.
When patients' labs are out of control and they say that they're taking their medicine, One really important question I always ask is, what did you have for dinner last night?
Well, same way with the CHF patients, I call in, my legs are really swollen.
Yeah.
Potato chips.
Ham, pork and beans.
Yeah. That's my favorite.
What?
Hot dogs.
Had a pack of hot dogs.
Yeah.
But I didn't put the salt on it.
Yeah.
I did not salt my hot dogs. Because I would just
All right.
Yeah.
Examples for when we want to use calcium measurements, when patients are reluctant to initiate statin therapy and who wish to understand more clearly the risk and potential for benefit. If patients are concerned about the need to reinstate statin therapy after they've discontinued for associated symptoms. Older patients, I really don't understand this because generally I find in older patients they already have calcification. So I generally don't use the calcium score in the really elderly patient like in their 80s, but in more of a middle-aged patient I would use the calcium score. So, and this new, actually next Friday's CAP conference is going to be on the new CTA-FFR about when to use that and how to use that more effectively. So, the plain calcium score, I find of benefit only if it's 0, and these patients that are coming back that have gone a calcium score at some place where they just do it for $35, then the question is what to do with these patients and whether to exercise them or use the CTA-FFR. I think that's something that I think we're going to learn as we go through using this, because the CTA-FFR I find to be an incredible tool looking for vascular problems. Okay, how to monitor these patients. Adherence to lifestyle changes is very important, and the effect of how your medication should be assessed by fasting lipid profile. And they recommend every 4 to 12 weeks after you initiate and 3 to 12 months afterwards based on adherence. What we routinely do is after we start therapy, we check somewhere between 6 months or 6 weeks and 3 months. With the PCSK9, when we start, we do it at 3 months because they've only had 6 doses by then, since they're only doing 2 doses a month. We also try and check people every 6 months. That keeps them honest. They know they're going to get lab. There's an incredibly high incidence of people being non-compliant with their medication, something like 90%. So if you think your patients are taking their medication, they're not, okay? And when we're checking them, and people stop their medicine and still go get their cholesterol done. Well, your cholesterol's 300. Oh, I stopped. Okay, well, let's get started back again, okay? So we routinely try to check people every 6 months. And the other thing is, if something's really going haywire, you also see that in their lab. But the most important reason to check them is to check for compliance and adherence with their medication. If they're not taking it, they're not having any risk factor reduction. And there is a very, very high incidence of non-compliance with medication. Looking at other age groups, in patients who are 70 years or older with an LDL level that's moderately elevated or above 70, initiate moderate intensity therapy. In adults 75 or older with functional decline, multiple comorbidities, frailty, reduced life expectancy, it's reasonable to stop their medication. And I particularly see nursing home patients when I'm out in my Jacksonville clinic, and I find that what I'm doing with those patients is stopping medication. There's no point in continuing it. It's excessive, it's unnecessary when they're already declining. In adults 76 to 80 with an LDL of 70, it may be reasonable to measure a calcium score. I'm not sure about that one because your calcium score is going to be high. But in your older patient, the issue is, for me, the issue is, are they vital, are they active, are they living independently? Those patients deserve treatment because they're the highest risk of having heart disease. Once their life expectancy declines, once their functionality declines, then it's probably unnecessary to treat them. Luckily, we don't treat children anymore, but in children and adolescents with lipid disorders, first, if they're having problems with obesity, that needs to be addressed and intensified lifestyle therapy. It is, however, these medications have been approved down to the age of 11, I believe. In children and adolescents 10 years of age or older, who do not respond appropriately to lifestyle therapy, initiate statin therapy. When we were treating children before we put the guideline of 18, I really felt uncomfortable giving statin therapy to somebody who was still growing. I felt more comfortable starting the statin therapy after their growth spurt and for young girls after puberty. But there are children that have cholesterols of 500, and fortunately, we're not dealing with them anymore, but the pediatricians have to deal with them, and pediatric cardiologists, and the recommendations are to start therapy even as young as 10 in these children. The 18-year-old that I have on PCSK9, she was identified at 2 because of a family history. Now, in infants and in that the toddler group, you do not make dietary changes because fat is so important for their brain development. So even if they're identified as infants, you don't start making those changes till they get at least 3 or 4 in terms of health, because that fat is so important for brain development as an infant. So praise Jesus, we don't have to see children anymore. But in family histories of very early heart disease or this severe hyperlipidemia, it is recommended that they start measuring. And again, the one that I have was detected at 2. I have a young lady who doesn't come to see me anymore, but when I saw her, she was pregnant and her triglycerides were 7,000. And when they did her heel stick at birth, her blood was milky. So, genetic problems are genetic. They start at the beginning.
Was she, is there a concern for the baby?
Oh, it was a nightmare. Yeah, it was a
Yeah.
whole nightmare pregnancy. Yeah.
Yeah.
She ended up in St. Louis. She ended up on a 10-gram fat diet, which is like 1 chicken breast. One thing, when you do have family hyperlipidemia, everybody needs to be screened. And so when you have somebody that's got a cholesterol of 3 or 4 or 500, you need to talk to them about their siblings. Their children should be checked. You'll have families where everybody has heart disease, all the aunts and uncles, the cousins, and so everybody needs to be screened and all their children need to be screened, which is, just a simple blood test. But when you find these familial hyperlipidemia and these really severe cholesterol problems, start talking to them about getting everybody checked, okay? It's very simple. And obviously you need to treat their metabolic factors or weight factors, but they're not going to, even getting them on a correct diet is never going to get their cholesterol anywhere to go on these patients. So children need even aggressive management when they have the familial hyperlipidemia. The important thing, though, is when you find people is to make sure that their children and grandchildren, everybody's being checked to identify who has this. We don't have to treat them. For anybody who wants to know, these are normal levels for children. Total cholesterol should be less than 170, triglycerides less than 75 or 90. HDL generally should be 45, LDL less than 110, and non-HDL less than 120. Actually, I think when infants are born who do not have hyperlipidemia, I think the LDL is like in the 40 range. Other populations at risk, you need to think about race and ethnicity in terms of defining risk, and review race and ethnicity features can influence the risk of heart disease and can influence the choice of statin and the intensity of therapy. Asian Americans in particular have a very high incidence of heart disease, and also if you look at the metabolic issues, they have an increased problem with statins. Their risk of heart disease starts at a much lower body weight and a much lower metabolic level, but they are much more sensitive to statins, and you need to think about that if you have Asian Americans. Latin Americans, Hispanic Americans, that's a very divergent group, and it makes a difference whether you're from Mexico or from the Puerto Rico area in terms of risk, but generally they tolerate statins very well. The African American population, again, blacks have a much higher risk of heart disease than whites, and black women show a very high incidence of heart disease compared to their white counterparts. They have a higher level of HDL, but a lower level of triglycerides. They also have an increased incidence of diabetes and hypertension. So race and ethnicity is very important in terms of risk, and it's also very important in treatment. In particular, with that Asian American, you need to be very careful of the statin dose that you're using. Lifestyle counseling is across the board in terms of everybody benefits from that. Here's where it is about the statin therapy in the Asian American, the Hispanics, and really there's no issues associated with statin therapy. Blacks have a baseline increase in serum CPK, but not necessarily an increased problem with the statin-associated problems. For Asian Americans, there's no separate guidelines. There are, for blacks, there's called a MESA, a multi-ethnic guideline that you can find. Hispanics, there's no specific guidelines.
Is it that they're sensitive to side effects of statins?
No, very sensitive to the statins.
The statins, so
Yes.
it's very effective. For
Yes.
They can use potentially
Very
lower
low,
doses.
yes, like 5 milligrams.
Okay.
Yeah.
Sure.
Hypertriglyceridemia. Hypertriglyceridemia is a different problem. It responds to different medications. In adults 20 years or older with moderate triglycerides of 175 to 500, address and treat lifestyle. Triglycerides, irregardless how genetically prone people are to triglycerides, it's still very diet sensitive. There are secondary factors that affect this, such as diabetes, liver problems, kidney problems, nephrotic syndrome, hypothyroidism. This can all affect and elevate triglycerides, and medications can also increase triglycerides. In adults 40 to 75 with moderate or severe triglycerides and moderate risk of heart disease, it's reasonable to reevaluate the risk after lifestyle and secondary factors are addressed. So if somebody's for one thing, if somebody's diabetes is not controlled, you're never going to get control of those triglycerides. If they're hypothyroid, you're never going to get control of the triglycerides till the thyroid gets treated. But it's reasonable to reassess the triglycerides and their risk once those problems get treated. But again, until they're under treatment, you're never going to get anywhere close to goal. It's reasonable to start these people on statin therapy because even though triglycerides lead to heart disease, the most effective treatment we have for everything is a statin therapy. Again, incredibly sensitive to diet, and when patients' diabetes is not controlled, this is never going to be controlled. In patients 40 to 75 who have severe triglycerides greater than 500, it's reasonable to address the causes of high triglycerides and initiate statin therapy. We see this 5 times a day in clinic. In patients with the very severe triglycerides greater than 500 and fasting triglycerides greater than 1,000, it's reasonable to identify and address other causes of the hypertriglyceridemia. If they're not diabetic, then this is a genetic abnormality. The interesting thing is, because it's very diet sensitive, as I explained to people, when you go through McDonald's and get a number 1, in an hour your triglycerides are going to be 5,000. Okay, because they cannot metabolize food and they're not clearing the triglycerides from their blood. So for these patients that have this very severe triglycerides, just a very clean eating is very important for them. It's a low-fat diet, avoidance of carbohydrate and alcohol. Alcohol is very important with this. Fish oil helps, and to prevent acute pancreatitis, fibrate therapy. When patients get to triglycerides of 2,000 or 3,000, they are at risk of pancreatitis, which is, a very severe problem. So treatment is indicated. Issues specific to women. Clinicians should consider issues that are specific to women, such as premature menopause, pregnancy-associated disorders, the hypertension, preeclampsia, gestational diabetes. Also, if the infant is small for gestational age or preterm deliveries. When discussing lifestyle intervention and the potential benefit for statin therapy. When I treat young women with severe hyperlipidemia, my golden rule is you stop your birth control, you stop your cholesterol medicine. Period, end of statement. You never want to get pregnant on cholesterol medicine, any form of cholesterol medicine. There's not much more to say about that. Don't get pregnant on your cholesterol medicine. Stop it. And don't check your cholesterol during pregnancy. You don't want to know.
Would it be good for them to do like a fish oil then, just to have something, or would that be effective at all?
Well, then you need probably a prescription fish oil because you don't know what the over-the-counter fish oil is contaminated with.
Okay.
Chronic kidney disease. In patients 40 to 75 with an LDL of greater than 70 who have a moderate risk for heart disease, treatment is recommended if their kidney disease is not treated with dialysis or kidney transplantation. And you need to also consider the risk-enhancing factors and initiate moderate intensity therapy. In patients with advanced kidney disease and require dialysis, treatment with LDL-lowering therapy, if it has already been started, it's reasonable to continue. However, if they're on dialysis and if treatment has not been initiated, it's probably not necessary to initiate it because these are really end-stage patients. So again, your patients with chronic kidney disease are very, very high risk. Inflammatory disorder and HIV. In your adults 40 to 75 years of age with LDL greater than 70 who have a moderate 10-year risk of heart disease, that risk is higher with chronic inflammatory disorders and HIV because these are risk-enhancing factors. And the risk discussion favors moderate intensity statin therapy or high intensity statin therapy. One thing you have to be careful with is what they're taking for their HIV because some of those medications you have to be very careful and use low intensity statin therapy. Our chronic inflammatory disorders, rheumatoid arthritis, psoriasis, lupus, HIV, a fasting lipid profile helps with the assessment for the risk of heart disease and a guide to benefit from heart disease and very aggressive monitoring. If their inflammatory disease is out of control, it might benefit to wait until the inflammatory disease comes back under control. And again, antiretroviral therapy for HIV, you need to really check your statin therapy and how it interacts with that antiviral therapy. In rheumatoid arthritis, undergo risk assessment with measurement of lipid profile and recheck lipid levels. Other major risk factors 2 to 4 months after the patient's inflammatory disease has been under control. So anybody who comes in who has inflammatory disease, HIV, think of them basically as at least moderate risk for heart disease. Okay? Statin safety and statin-associated side effects. To talk to your patient before initiating statin therapy to talk about the net clinical benefit, the potential risk reduction for heart disease against the potential for statin-associated side effects. I honestly don't know what the risk of myalgias are in the general population. You know, in my clinic it's 95%, but I don't know in the general population what it is. It's supposed to be like 5 or 10%. The other thing I can tell you is if a patient gets muscle pain, they're not going to take it. Period, end of statement, okay? They're not going to take it. Then non-statin therapy or other, basically those patients are very difficult, and thank God for PCSK9 for these patients that are at moderate to high risk, that are very statin sensitive. They're not going to take it if they have muscle pain, I'm just telling you. I don't care what they tell you, they're not taking it. In patients with indications for statin therapy, identification of potential predisposing risk factors for the side effects include new onset of diabetes, it's recommended that they be checked for that before initiation of treatment. In patients with the side effects that are not severe, sometimes you can talk a patient into re-challenge with a very low dose of a statin, but you're really running an uphill battle when somebody's had muscle pain from statin therapy. You really are. In patients with increased diabetic risk and new onset of diabetes, there is this concern about a side effect of statin therapies being the initiation of diabetes, that statin therapy can cause diabetics. So in patients with increased diabetic risk or new onset diabetes, it's recommended to continue the statin therapy with added emphasis or adherence to net clinical benefits, and also lifestyle changes, physical activity, healthy diet, dietary pattern, and moderate weight loss. So your diabetic patient, if you start statin therapies, it really should not make the diabetic worse. If you have somebody who's a borderline diabetic, that increases the risk of the statin therapy causing the diabetes. CPK, in patients treated with statins, you can check a CPK if they have severe statin-associated muscle pain, objective muscle weakness. Generally, they've already stopped it by the time that's happening. Measuring liver transaminases as well as bilirubin and alkaline phos if their symptoms suggestive of hepatotoxicity. Generally, by the time those symptoms have started, the patients have already stopped the medication, but it is reasonable to monitor those if there's any muscle weakness or problems with the liver. In patients with chronic and stable liver disease and non-alcoholic fatty liver disease, which I think everybody has, when appropriately indicated, it's reasonable to use statins after monitoring baseline measurements and determine a schedule for monitoring and safety checks. So a lot of our patients that have fatty liver disease have normal liver enzymes. Some of our patients with fatty liver disease have a mild elevation in liver enzymes. And if you feel as though it's important to start a statin, what I recommend was probably check the liver enzymes every time you check the lipids to make sure that the liver enzymes are staying stable. And if the liver enzymes start elevating, if they get to 3 times that baseline, you need to stop. Sometimes with these fatty livers, once you start the statin, you'll see a little bump in the liver enzymes and then it goes back down. But if it doesn't go back down, if it keeps climbing, that's when you need to stop. Patients with an increased risk of heart disease with severe statin-associated muscle symptoms or recurrent statin-associated muscle symptoms, despite appropriate statin challenge, it's reasonable to use a clinical trial proven non-statin therapy such as Zetia, bile acid sequestrants, or PCSK9. And like I said, once they get muscle pain, they're not taking it again. Everybody asked about coenzyme Q. It's not recommended for routine use or to treat the symptoms of the muscle pain. And in treating patients with statins, a routine measurement of CPK and If patients aren't symptomatic, if they're otherwise healthy, you generally don't need to check the CPK or the liver enzymes. Myalgias, they say 1 to 5% in clinical trials, but in observational studies, 5 to 10%. In my clinic, 95%. Predisposing factors are, as people get older, female sex, low body mass. Those tiny little old ladies, they have a very high incidence of it. When you have some of the enzyme inhibitor problems, comorbidities, HIV, again, you have to be very careful with their medication if they're on antiretrovirals. Renal disease, liver disease, thyroid disease, pre-existing myopathies put them at very high risk, and some of our patients that have like the dystrophies, there's a lot of, I've seen a lot of neuromuscular wasting and weakness in some of our men. I think some of it may be Desert Storm associated. Boy, that's really hard. When they're already having muscle weakness, that's very hard to put them on anything that would make it worse. But those are things that make people at higher risk. The incidence of myositis is very rare. The incidence of rhabdomyolysis is very rare. The incidence of autoimmune myopathy is very rare. And again, here's the nuance at diabetes. It depends upon the population. More frequent if the patient is at risk for developing diabetes, and factors such as a high body mass index, elevated fasting blood sugar, and metabolic syndrome put the patient at more risk of developing diabetes from statin therapy. Transaminase elevation 3 times more than normal is infrequent. Hepatic failure is very rare. They say memory and cognition is very rare, but there are people that come in and tell you they just don't have very good memory. Once they stopped it, it got better. So I'm not sure what the incidence really is of the memory and the cognition. There's no associated incidence of cancer with statin therapy. Other side effects, renal function is not generally affected. They're not associated with cataract therapy. They're not associated with tendon rupture, not associated with hemorrhagic stroke, probably no association with interstitial lung disease, and probably not associated with low testosterone. So implementation. So intervention is focused on improving adherence. As I said, people don't take their medicine. Recommended for management of adults with elevated cholesterol level, including telephone reminders, calendar reminders, interdisciplinary educational activities. We try to give them as much education as we can. Pharmacist-led intervention, that occurs in cardiac rehab. They get a lot of that. And simplification of drug regime, such as once a day daily dosing. This is very labor intensive, and this is not income producing, very low and very high intensity. It's important that clinicians, health systems, and health plans identify patients who are not receiving guideline-directed medical therapy, and your insurance company knows what you're doing. We get lists of people not picking up their medicine. And this should facilitate initiation of appropriate guideline-directed medical therapy. And remember, the guidelines work if we as clinicians use them and if our patients use them. Before therapy is prescribed, you need to have a discussion about the potential benefit and risk reduction, adverse effects, drug interaction, and the patient preference.
Is there much problem with them starting and stopping the medications? If they come in and they say they're not taking it, and we start them and then keep doing that over and over again. What are the ramifications?
Well, I have one guy who every 6 months he comes in and his cholesterol's high, and we start the medicine, and then that lab's good, and then he stops it. And then he comes in and that lab's high, and we restart again. I have somebody that we do that cyclically with. Unfortunately, he's able to tolerate it. But generally, restarting a medication can have increased risk with side effects. But people don't take their medicine.
Are you saying that every time you restart the medicine, the likelihood of side effects is greater?
I think so.
Is that right?
Yeah. A little bit. I mean, some people do it quite well, but it seems like restarting it causes more problems. Yeah. Cost and value. Obviously, the lower the cost, the better value. That's a I see ER as cost and evaluation. I can't really think of it, but it's a program that looks at the cost of your quality life years gained, and if that cost is less than $50,000 per quality life year, then it's reasonable. Intermediate value is 50 to 150,000, and a low value is greater than 150,000. So when you look at the orange line is PCSK9 right now, which is just obscene. It's nowhere close to where it should be. And basically, to get to an appropriate cost value level, the cost needs to drop 75%. So
$600 a month off our insurance.
What's that?
That drug. $600 a month is my part.
After insurance.
After insurance paid.
It's about $2,000 a month.
So when do you think that might get to be a more reasonable price?
You know, there's a lot of national pressure on them, probably, and one of the reasons is because these medicines are so effective and they've turned out to be so much better than we thought that they were going to be. So there's a lot of national pressure. There's pressure on the insurance companies to improve coverage. I know some of the companies have actually made contracts with some of the insurers, dropping the cost and supposedly making it easier. So there's continued pressure on them.
I think one of them dropped by like 60% at the beginning of the year. That's what they told me. So I don't know.
Which one?
Prialant had made a public campaign that they were dropping their price, but I don't know that it.
But you have to
I think it's still very expensive.
But it's
but,
like the dose. Like they did that and they mandated you to change for it, but the dose of the Repatha at 75 needs to be 150 for the Prialant for the same effect, at least for me personally, because my cholesterol went right back up on Prialant, even in the presence of.
So on your Prialant, are you still paying $600?
Yeah, that's what I'm paying $600 on.
Well, so that didn't work so well.
Yeah.
Yeah. So
it might have helped the the insurance company maybe paying less, but I'm still paying.
Well, you have a copay card, don't you?
Mm-hmm. So when I meet all the deductibles, I'll eventually. It's until I meet deductibles, or gonna get out of pocket paid for the start of this year. It's $600 a month, so it'll be a couple more months of $600 a month before.
Yeah, they're incredibly expensive.
Really expensive. But I swear by the drug.
Yeah, they're great. Yeah.
Swear by the drug.
Yeah, people feel great on them. I've had one or two patients that haven't responded, and I think they don't have the genetics to respond. And the other thing, since we're not drug sponsored here, some very low body mass women really only need it every 3 weeks. You know, so okay, here's all you need to know. Okay.
Why did we start here?
I put it at the end. Well, we're doing good here. Top 10 take home. In all individuals, emphasize a heart healthy lifestyle. Here's where they finally get to it. A heart healthy lifestyle. In a healthy lifestyle, reduces atherosclerotic cardiovascular disease risk at all ages. In younger individuals, that healthy lifestyle can really reduce the development of risk factors and is the foundation for risk reduction. In adults 20 to 30, an assessment of lifetime risk facilitates a clinician-patient risk reduction and emphasizes intensity of lifestyle efforts. In all age groups, lifestyle therapy is the primary intervention, irregardless of what else you're doing. In patients with clinical heart disease, with clinical vascular disease, reduce the LDL with high-intensity statin therapy at maximally tolerated doses. The more LDL is reduced on statin therapy, the greater will be the subsequent risk reduction. And use a maximally tolerated statin dose to try and get your LDL greater than 50% reduction. These are your high-risk patients that already have basically your secondary prevention. In high-risk patients, use an LDL threshold of 70 for treatment to consider addition of non-statin therapy to statin therapy. Very high risk includes multiple major cardiovascular events or one major cardiovascular event and major high-risk conditions. In your very high-risk patients, it's reasonable to add Zetia to maximally tolerated Zetias, to maximally tolerated statins. And in the very high-risk patients and maximally tolerated statins and Zetia, PCS may be feasible. In patients with severe primary hyperlipidemia, go ahead and treat even without calculating. And if an LDL remains greater than 100, consider adding Zetia. If LDL on statin plus Zetia remains greater than 100 and the patient has multiple risk factors, a subsequent high rate of heart disease, then PCSK9 inhibitor may be considered. In patients 40 to 75 with diabetes and an LDL greater than 70, start your moderate intensity statin. These patients with diabetes that are high risk, especially with multiple risk factors, and it's reasonable to use high intensity statins. In adults 40 to 75, evaluated for primary prevention, have a clinician-patient risk discussion before starting statins. And that discussion should include a review of major risk factors such as smoking, elevated blood pressure, elevated hemoglobin A1C, and a calculated 10-year risk. Also consider the presence of risk-enhancing factors, the potential benefits of lifestyle and statin therapy, and the potential for adverse effect and drug-to-drug interactions, and consider the cost and benefit of your therapy. Also consider patient preference and their values in a shared decision-making process. The patient has to be part of this or they're not going to adhere. In adults without diabetes and an LDL greater than 70 at a moderate risk, start moderate intensity statin therapy if a discussion of treatment options favors statin therapy. And again, consider your risk-enhancing factors. And if the risk is uncertain, consider using a calcium score to improve your specificity. In patients without diabetes and a moderate risk for heart disease, your risk-enhancing factors, and again, those risk-enhancing factors are an elevated ApoB, high-sensitivity C-reactive protein, ankle brachial index that's abnormal, and a high lipoprotein A. In adults without diabetes and a 10-year risk factor, risk disease that's moderate, if a decision about statin therapy is uncertain, consider and measure the calcium score. If the calcium score is 0, treatment with statin therapy may be withheld or delayed, except in smokers and those with diabetes or a strong family history of premature heart disease. If the calcium score is 1 to 99, it favors statin therapy, and particularly in older patients. And for any patient, if the calcium score is greater than 100, statin therapy is indicated. Access, adherence, and percentage response to your lipid-lowering medications and lifestyle changes with repeat lipid measurement 4 to 12 weeks after statin initiation or dose adjustment, and repeat every 3 to 12 months. It defines a response to lifestyle and statin therapy by a percentage reduction in LDL compared to baseline, and in your very high-risk patients, triggers adding a non-statin therapy if the LDL remains greater than 100. Okay, I wanted to include a few recipes and some thoughts from Lipid Clinic. One of my patients had a recipe for mac and cheese. Once you put your elbow macaroni, add a can of sweetened condensed milk, a stick of butter, and a block of cheese.
A whole block of Velveeta? Or
Yes.
which one? Wow. That's a lot.
And for the turkey, stick a stick of butter up the ass and roast it.
Oh my God.
Now, I have to say, my Morton salt box, I just had to replace after 30 years. I had one patient that was going through a box of Morton salt every week.
Wow.
I have a recipe to add. This is from my previous coworker's stepdad. A Shane stick. Cover a stick of butter in sugar and eat it. One spoon at a time. A Shane stick. Can you imagine?
It makes me so stomach.
I've heard of bedtime ice cream for a snack, but I had one patient that was using half gallon of ice cream at night.
Wow, my belly would hurt. And I'm a good
One of my
eater.
patients said I eat fish every week, and his fish was Long John Silver. It's cherry Coke with fruit. If you have IBS and you can only eat ice cream, just do 7 gallons a week. And then the classic, which it happens more often than you know, don't throw away your old medicine, just mix it and take a different pill every day.
Oh my god.
So,
Let's see.
questions?
Wow. I have a question about the patients who, I've had some patients lately that are not the triglycerides you see, they're in the more the 750 to 1500 range, with a maximally tolerated statin. They do have, we're doing secondary prevention, so they've had a coronary event already, so they're on moderate to high intensity statin. The triglycerides are still coming back, obviously some of it's diet, but so I've added Meseta as opposed to over-the-counter fish oil recently. Previously I did fish oil, but what do you, I mean, you don't add a five rate in this range necessarily, right?
Not necessarily in that range, but if they get much higher, I do. And you know, there's not a lot of medication for it. So again, these are the patients that when they eat a high-fat food are going to go sky high. So,
Are you using the Meseta much at this point compared to fish oil or the counter? Trash was very impressed by the Reduce It trials, which was released, of course, the same day as the new guidelines, so they're not new guidelines, but we've prescribed it for some people, and I haven't really seen them back yet to find out do they get really any further reduction in the over-the-counter fish oil. I know it's one study that shows risk reduction associated with it, but
I think we've tried to do it, and we've had pushback from the insurances.
yeah, I'm not sure how much it's costing
Yeah.
people at this point. They don't use it that much.
I think I only have 1 or 2 on it, and I haven't seen it back, and the other people that we've tried, their insurances have blocked it.
So you just do the over-the-counter fish oil then.
We spend so much time getting PCSK9 approved, I'm not adding Vestate, but trying to get approval.